shrink down my talks to 20 minutes, as we have 14 minutes left until the shuttle leaves to the restaurant. So it will be more of a pictorial essay then. And there's one phenomenon that I personally find very interesting and absolutely unpredictable, but maybe someone in the audience has another insight on that, because some stenosis are improving by themselves, others are worsening, and some of the restenosis are spontaneously remitting. And I've just collected some pictures, and I'll begin with the spontaneous remission of de novo stenosis. So this was also an acute setting, a young man with an M1 occlusion and an underlying stenosis. At least you could guess that after this maneuver, there's some material in the artery, and the narrowing of the stent markers during the retrieval gave some hint to an underlying stenosis, because all the markers of the 6x40 arperio narrowed over this part of the M1 segment. So this is already the first question. What would you do in this case after this pass? Proceed with further mechanical thrombectomy maneuvers, administer GP2B3A antagonists, and wait for resolution of the findings. PTA or stent PTA. So please vote. Do you have the question? Okay, I think we're finished. No, there are still incoming answers. That's approximately what I expected, that it's not very homogeneous. Yeah, it's almost equal. Stent PTA or proceed with further maneuvers. So next slide, please. Okay, it's not. So we decided to go on for PTA and stenting in this case, very straightforward, and administered also, of course, GP2B3 antagonist agrastat in this case. And this was a neurospeed balloon and a Credo 3.0 × 20 stent, providing this result with a TK3 result. And here you see the 3 months follow-up. The patient was asymptomatic. So what would you do then in this high-grade stenosis after 3 months? Okay, the PTA bar is shrinking. Okay, so next slide, please. That's what we did. We waited and did another control after 6 months with a very nice result. So we had a spontaneous regression of the in-stent stenosis, and also the temporal branch is still patent, and its diameter is increasing also. So we have an increase in both the diameter of the stented vessel segment and the diameter of the side branch. This is an old man with a right A3 occlusion. He was in a very bad neurological state, so high NHSS grade of, no, he was only an NH3 but fluctuating. And so we had a discussion with neurology and decided to go for this anterior thrombectomy. They suspected an MCA occlusion because of his clinical findings, but finally we decided to go for this occlusion. This is a 5 French Sophia together with an Aperio 2.528 stent retriever. And after the first pass, there's some recanalization with a bit of a distal thrombus in the distal A4 or almost A5 segment. So we performed another maneuver, the same technique. And then we went for a PTA because of a residual stenosis. And this was the result after the first PTA. And we decided to go for stenting with Credo 3.020. This is the final result. Some small embolic infarcts in the ACA territory. And this is the 3-month control. And if we take a very narrow look, on the left screen, you can see marked with a red arrow a bit of a narrowing in A3 and improvement in the side branch again. And this is again post-stenting on the left side with a very narrow side branch, the callosal marginal artery probably, and on the 3-month follow-up residual stenosis or relapsing stenosis, but an improvement of the side branch. So this is the other way around in the constellation. Next case, also acute thrombectomy setting with an M1 occlusion and a narrowing of the distal M1 segment post-thrombectomy. And again, we took the decision to go for stenting and balloon angioplasty after reocclusion after 10 minutes. And this is the result. Underdilated PTA with a neurospeed balloon and a 3.5 Credo stent. Hemodynamically nice result and a high-grade relapsing stenosis after 3 months. But the patient was fine, so we did nothing and waited. And after 1 year follow-up, you see that on the right slide, the stenosis is still there, but the patient is still fine. So there was no change in neither direction, and we decided to go for conservative therapy and do only further controls in case the patient has any clinical signs correlating with the right MCA. This is a completely other case, aneurysm treatment with a stent-assisted coiling and a Leo stent, and 1 year follow-up, which is our usual regimen in aneurysm stent-assisted and aneurysm-treated controls. And we see quite a bit of a narrowing in the left P1 segment. And after 2 years, we did another control because the patient had some visual symptoms that were most likely attributed to the left PCA territory. So we went for a paclitaxel-coated drug-eluting balloon PTA and did another control after 1 year, and this showed a very nice result. And in our experience, the results post drug-eluting balloon PTAs, be it in atherosclerotic disease or in cases like this, in aneurysm treatments, shows very nice results with very rare relapsings. Again, an aneurysm case, a very broad-based parathalamic carotid aneurysm that was treated with a Derivo 2 4 mm flow diverter and coiling. And at the end of the procedure, you see some fish mouthing on the left side, which we post-dilated with a balloon. Achieved this result, and on the right screen you see the 6-month control with a stenosis and some intimal thickening in the inner curve. Again, 6-month control on the left side, another 6-month control at 1 year with complete resolution of this finding without any change in medication. She was still on monotherapy with 100 milligram aspirin per day and clinically doing fine. This is a V4 stenosis treated with an Aclino. This was the time before we had the Credo stent, and a 4 mm Aclino stent with a nice post-stent PTA result. And at the 6 months control, we see a very short stenosis in the distal stent segment, approximately at the level of of the origin of the contralateral V4 segment, and this is the 1-year follow-up where this residual stenosis completely resolved. So this is the other way around. We had a stenosis and it didn't get worse, but it just completely resolved without any additional treatments, which is in line with some institutions who go for stenting only in perforator-bearing intracranial segment stenosis and report the self-expansion of the stent being able to resolve the stenosis by themselves. Here again, V4 stenosis. 6-month control at the left side. It was also a thrombectomy case with acute occlusion and improvement of the stenotic segment at 18 months control. So it's really hard to predict which case will develop in the good and which one in the wrong direction. So to conclude, relapsing as well as remitting stenosis are common phenomena. Early clinical asymptomatic findings should not give cause to serious concern, in my mind, as long as they're asymptomatic. Waiting for consolidation for at least 1 year seems to be reasonable. And post-dilation with drug-eluting balloons provide good and stable results, but should be indicated with cautions, because also with a drug-eluting balloon, of course, we can occlude perforators. And we should undersize PTA of ICAD, which doesn't seem to be associated with the occurrence of restenosis. So we see restenosis in completely dilated segments and in underdilated segments. I don't see any relation in this. Thank you very much. We can go directly to the next talk, to leave enough time for Maxime's talk. Or maybe if there are any questions, meanwhile, while they're trying to find the presentation, I'm happy to answer all questions. Yeah, yes.
For these nice examples. And I think it's very good to wait, not to treat without any symptoms. But I think the risk of perforator stroke is less within this restenosis because you have this intima hyperplasia. And we always perform first PTA with a normal balloon because it's better navigable, and then with a shape.
A drug-eluting?
Drug-eluting balloon, thank you. Yeah. And I haven't seen any perforated strokes in reperforming this with a drug-eluting balloon, because I think the risk is less, just this comment.
Okay, maybe I can show one of my bad experiences with that now. When we are talking about the snow plowing effect in perforator-bearing segments, I'll just start right away. The effect is called the snow plowing effect because of the similarity to these big machines who just push the snow away from the main road and don't care whether they occlude the side branches and the small side roads and the entrances to houses and whatever. And I think our PTA balloons are very strong, and that's why it's nice to compare them with this snow plowing effect. And if we look at the amount of perforators that can arise from an M1 segment or from the basilar artery, it's really impressive how many vessels arise from these segments. So what is the nature of these perforators? In ICAD, perforator infarcts account for approximately 25% of all strokes. And there are a couple of publications who divided the mechanism of stroke, such as this one where perforator strokes accounted for 21 and artery-to-artery embolism for 46. Other, like in situ thrombocclusion, 19%, hemodynamic only 1%, which seems to be pretty low, I think. And another trial by Lopez Cancillo from 2013 found also more than 20% being caused by perforators. And if we look at the location and comparing anterior versus posterior circulation, we see that artery-to-artery embolism accounts for 52% in the anterior circulation versus 34% in the posterior circulation. And it's the other way around with perforator branch occlusions, where 12% account for strokes in the anterior circulation and 40% for strokes in the posterior circulation. So apparently, as some of the speakers also stressed today, perforators are mainly responsible for strokes in the posterior circulation. So Sampras, I just want to highlight one thing that that changed, that local perforator in fact accounted for 12 out of 224 patients, which is approximately half of all complications. And the authors state that distal symptomatic embolic stroke as an immediate complication of angioplasty and stenting was uncommon. So we're really talking about bleedings and perforator strokes and not about embolic complications in this study. I'll skip that. The Weave trial, the Visit trial, we've seen that today. And so I'll just go through some examples of perforator occlusions, symptomatic and asymptomatic. This is a proximal symptomatic M1 stenosis before treatment. And this is after 2 millimeter PTA. And this is after stenting with a neuroform stent. Very nice angiographic result. And this is the MR post-interventional. Luckily, this patient recovered very well from this basal ganglia infarct with MRS 0 at 6-month follow-up, but still it's quite a huge infarct that was probably caused by one of these small perforators that we can hardly distinguish here. Another proximal M1 stenosis. Looking at perforators, I would say there are certainly 2 distal M1 perforators that arise exactly on the opposite side of the temporal branch. But in the proximal M1 segment, there doesn't seem to be that many perforators. So treatment was performed and the patient had no infarct. So it was nicely predicted that this procedure would go well. Again, M1 stenosis. Are there any perforators surrounding the M1 segment? The majority of them seem to be in the proximal M1 segment, so there's not a big matter of concern, but it's also hard to say whether one of these crossing vessels in the distal M1 segment is a perforator or not. And this patient had a basal ganglia infarct, but it was asymptomatic, and the angiography result was very nice. Before, after, I don't see any occluded vessels. So getting to the posterior circulation, we have the basilar perforators that are the rami ad pontem and the circumferent or transverse pontine arteries. And arising from the V4 segment, we also have medullary perforators that are corresponding to the and that give also rise to the anterior spinal artery. And this is a case of a basilar artery stenosis and a very small ICA arising from the proximal portion of the stenosis. So I think everybody would agree that a strong dilatation could cause an ICA occlusion in this case, at least, if not any other perforators. So we decided just to place a microcatheter inside the ICA, which is a 17 microcatheter, and then go for angioplasty, just to keep the ostium of the vessel open during angioplasty. And that was the case. We still see the ICA after the procedure, and we had 2 very small DWI lesions in the ICA territory. So side branch occlusion, of course, is not evidence-based at all to protect it with a 17 microcatheter, but at least it could be an idea to have something inside the vessel to protect the snow blowing effect. Here we see a very I can't point on it. A very small perforating artery that originates from the normal diameter V4 segment. I hope everybody can see it. It's seen on both planes right at the beginning of the stenosis, and certainly it's an important medullary perforator. But there was no concern for dilate because this perforator was arising from the somehow healthy vessel segment. So PTA was performed. On the left side, you see again pre-PTA, on the right side post-PTA, and the perforator is gone. It's not visible anymore, and it was a catastrophe. The patient had this paramedian medulla oblongata infarct, and still on 6 months follow-up, he was in a bad condition with an MRS score of 4 points. Again, a case of a rising side branch, V4 occlusion with a big pica, and same procedure. It was protected with a small microcatheter and then PTA'd and stented, and it remained nicely open. This is a symptomatic basilar artery stenosis just below the ICAD, and here was no concern because it was really below it and it nicely stayed open. So to conclude, cautious indication and selection in perforator bearing segments have to be made, and we really don't have any strong predictors for whether we are going to occlude perforators or not, even if we think that we are on the safe side, because in the segment we don't see any perforators. So we should concentrate on hemodynamic relevant stenosis, on recurrent infarct despite aggressive medical management, as we've discussed today, and of course the acute therapy in the setting of mechanical thrombectomy. Thank you.